Hello everyone. Welcome to Eyezone Education's webinar series. Thank you for joining us. Before we get started, let me share with you a little housekeeping. Please note that this presentation is being recorded. In order to be eligible for a certificate, please fill in the attendance sheet in the link which will be provided in the chat box. To applaud, please use the clapping hands function which is in the reactions button along the bottom toolbar. In order to see the speaker in full screen, please select Speaker View instead of Gallery View in the upper right corner of your Zoom screen. Switch your video off and mute the microphone to avoid intervention. This will conserve bandwidth and facilitate a smoother conference experience. Please type your questions into the chat box in your control panel and select the option to send them to the host or the co-host. Note that questions will be filtered for the Q&A at the end of the webinar. We will do our best to accommodate all your questions. Attendees may be asked to participate during the session. Please click the Raise Hand button in the Emoji tab to speak and then unmute your mic. Make sure to mute your mic when you're done speaking. Thank you for your cooperation. Today's topic is Pediatric Low Vision, Evaluating and Managing Vision Loss in Children, to be presented by Head of the Optometry Department at An-Najah National University in Palestine, who is none other than Dr. Ithar Beshtawi. Our esteemed presenter for today is an assistant professor in optometry. She is the head of the Optometry Department and the Optometry and Low Vision Clinic at An-Najah National University in Palestine. Dr. Beshtawi had taken part in a Tempus winning project with universities and organizations in Europe and the Middle East titled Curriculum and Skill Development in Vision Rehabilitation, which aimed to improve the quality and quantity of the services for persons with visual impairment by developing university curricula and training resources on vision rehabilitation, in addition to the establishment of a multi-disciplinary network of vision rehabilitation professionals determined to support the development of comprehensive services in the region. Subsequently, a low vision center was established at An-Najah to be the only center in the northern Palestine which provides low vision assessment and rehabilitation services. Dr. Beshtawi has also participated in the JUSUR program for vision rehabilitation of partially sighted Palestinian youth. In her academic field, she has published many research articles in high-impact factor scientific journals, received a number of awards and travel grants for her contributions to research, and has been invited to present research papers in numerous national and international conferences. In this 40-minute session, Dr. Beshtawi will share insights on evaluating and managing vision loss in school-aged children. Without further ado, let's give a warm welcome to Dr. Ithar Beshtawi.
Good evening, everyone. So this talk will be divided into 3 parts. The first will be a brief introduction about visual impairment in children, talking about definition and causes of visual impairment. The second part, we will talk about how to perform the visual assessment in children, and it will highlight on the most common signs of visual impairment in children that we need to pay attention to. And in the final part, we'll talk about the visual and non-visual optical aids that might be prescribed to school-aged children to help them use their remaining vision to the maximum potential. So our talk today is about vision in children. So why it matters? Actually, vision is the most dominant of our senses, and it is important for the children's development from the minute they are born. Visually detecting and responding to parents and family members helps even infants to develop their cognitive and social skills, as well as their motor skills, coordination, and balance. Additionally, vision is very crucial to educational attainment from early childhood through the adolescence, because it allows easy access to the instructional resources. And not to mention that vision encourages the growth of social skills in order to establish friendships, boost self-esteem, and preserve happiness. And we know that participation in sports and social activities is also vital for physical development, mental and physical health, in addition to personal development. But when the visual system and one or more of its visual function are affected by some of the eye conditions, vision impairment could occur, which has a major ramification for the persons over the course of their life. However, prompt availability to high quality eye care and rehabilitation can help to alleviate many of these problems. So how can we determine if the child has visual impairment or not? The WHO considers that a person has visual impairment when his or her visual acuity is less than 6/18 to light perception, or a visual field less than 10 degrees in the best eye with the best possible correction. And it classifies visual impairment into categories from 1 to 5, depending on the visual acuity. So the categories from 1 to 3 are the visual impaired persons. So if the visual acuity is between 6/12 to 6/18, it's considered as mild impairment. And if the visual acuity is between 6/18 to 6/60, it's considered as moderate vision impairment. And if it is between 6/60 to 3/60, is considered as severe visual impairment. So before we continue, let's ask ourselves a question. Is it common to have visual impairment in children? If we look at the table in this slide here, which shows the global estimation of the number of visually impaired people among ages, and concentrate on the pediatric age, we can find the answer, which is yes, it is very common, and the prevalence is quite high. So now let's discuss what causes visual impairment among our children. Actually, it is very essential to identify the pathology behind visual impairment. Not only it is needed to consider whether medical treatment is required or not, but also to understand how the disease affects the visual functions and to ultimately develop the disease-specific visual rehabilitation management plan. Here are some of the most common leading causes of visual impairment in infants and babies, which include albinism, whether it's oculocutaneous or ocular albinism, congenital cataract, congenital glaucoma, in addition to macular coloboma, Leber's congenital amaurosis, and optic atrophy hypoplasia. Here we can see a few more examples, which includes cerebral blindness, congenital idiopathic nystagmus, primary hyperplastic vitreous retinoblastoma, and retinopathy of prematurity. Here we can see some of the causes of visual impairment in older children. For example, we have the Best disease, optic atrophy, Stargardt's disease, and retinitis pigmentosa. Now let's talk about the visual impairment evaluation. So while optometrists may not make the diagnosis itself, they can provide reassurance to the parents and also an explanation of the disease process that may not have been provided initially. So they can explain aspects like what a child is capable of seeing, how might it compare to normal vision, and how might the child's vision loss make his life functionally more difficult or not. Additionally, optometrists can, of course, do the visual assessment, rehabilitation, and give recommendations to be applied at home or at school. So in order to help the children with visual impairment to use their residual vision to its maximum potential, we need first to understand their visual abilities in order to provide them with the appropriate aids, training, and advices. So the low vision assessment in general is a problem-solving exercise to which there is no one correct solution, and it can be broken down into three main steps. In the case history, which is the first step, you find out what the children need and their parents' concerns. Then you assess the child's current visual function. And once you know what the child wants and his parents' concerns and what they can see, you try to find the most suitable solutions or ways to achieve their goals. So the visual assessment in visual impairment children may not differ from the visual assessment for people in general, but choosing the suitable target for your assessment is the most important part. So when trying to perform testing, remember that the visual impaired children is a children. So toys will be useful to keep the child happy and paying attention to what you want him or her to do. Use fixation grabber toys. There are widely available with various features and range of details and contrast. You can use the animal and character figures or pen light and flashlight with colored caps, maybe some toys that make noise, others which move or sparkle, and the touchable ones can be used as well. And remember that the child may feel more comfortable with his mom than you. So you may use her in your assessment. So the case history in a low vision assessment is usually longer and more in-depth than a normal eye examination. The success of low vision assessment is often down to this important first discussion with the parents and the child if he is old enough. You will need to involve the parents, especially with very young kids, and encourage the child himself and their parents to open up and share their experience and feelings, assess their motivation, and find out how well they are functioning in all aspects of their lives, not only in schools. So from the moment you meet the child, you can get a lot of information by assessing if they look straight at you or use eccentric fixation, if they are sensitive to light, they would wear a tent, a peaked hat, or shielding their eyes. And if they need you to guide them, or can they orientate themselves independently. Actually, you can also ask the parents about the prematurity of the child, if he was born before 9 months or not, because you could suggest or think about cortical damage that could happen to the child, and that was the cause of the visual impairment. Additionally, during the visual history, you need to get information about the pathology itself, if the parents know the diagnosis or not, and if they know the condition itself and its prognosis, the onset of the impairment, duration and circumstances. You can ask them also about the stability of their child's vision, describe of what they can see and they don't see, if there's any difference between the two eyes and if there's one eye better than the other or not. If they are using any treatment, if they used it in the past, or there is any current treatment or future treatment they are thinking of, and if the child is using any spectacles or low vision aid. Also, you can ask the parents if their child usually do any suspicious behavior, because many children will exhibit usual behaviors as a result of vision impairment. And it is important for you as an optometrist or eye healthcare professional to know what is normal and what is not, and what some of these behaviors might mean. So if the child's do eye pressing most of the time, it's an indicator of poor vision, and it is usually due to retinal problem or high IOP, which could potentially damage the eyes. And if the child holds things very close, this could be due to increased accommodation demand. And if the child tilts or turns his head, he's doing so to fuse or dampen nystagmus if he has nystagmus, or to put objects in the preserved visual field, or even to allow for muscular or spinal problems. Eccentric viewing suggests that the child is trying to use non-central referred retinal locus, or to use eccentric positioned macula. And if the child keeps shaking his head, this means that the child is trying to nullify the nystagmus. And if they're doing light gazing, this suggests very poor vision, which might be okay if he's not looking at the sun. Then we transfer to the other test, and we start with the fixation and ocular motility test. In this test, we assess the child's ability to fixate and track and objects, and we assess the wideness of their the action of their ocular muscles. Then we check for visual acuity, and actually for visual acuity testing, there are a variety of test options which you can choose the most suitable for your patients, and try always to try the most complex one. You do have the Cardiff acuity test, the grating acuity test. You can also choose matching or picture matching visual acuity tests. So the Lookmark distance visual charts are very much more useful within the low vision context. The chart should be held close enough so that the patient can read a line or two of letters, but not all the lines on the chart. The visual acuity can be measured using this equation written in this slide at any distance. And it is very important to give the child time and encourage them to use eccentric viewing. When testing a letter chart, keep in mind that the amount of crowding on chart will affect your measurement. Very good single letter acuity is not as good as when you're testing with crowding. So you must encourage guessing. You can also encourage guessing by employing matching cards, tracing, and apply whatever it takes you to take your measurements. And just as you would with other kids, you need to keep in mind that the child can gain unintentional clues. So get it through or enough trials to estimate the visual acuity. And we need to take refraction measurements because high and shifting refractive errors are more common in the low vision populations. And you must know the true visual capabilities in order to provide an appropriate rehabilitation for the child. It is important to do retinoscopy in all low vision children, although it might be challenging in some cases. During subjective refraction, always be patient and take your time when refracting a child with visual impairment. The phoropter is not recommended at all to use for the visually impaired patients, especially with the children, because it does not allow the person to use their habitual head posture or eye position. And it is not easy to use with large incremental changes required in visual impairment assessment. Autorefractors are also not advisable to use because they are not accurate due to the difficulties with fixation, small pupils, and media opacities the child might have due to their visual impairment pathology. After that, we test for contrast sensitivity, and we use hiding Heidi cards. It is a child-friendly test, which has multi-cards with a smiling face Heidi with range of contrast. You can bring cards closer until the child gives you a response to where the smiling face Heidi is by pointing or even verbalizing. Apply entertainment values when performing this test, like asking the child to search for Heidi and to say bye-bye to Heidi when you are done with this test. After that, we test your visual field. Visual field in low vision assessment is required to give an understanding of the field of view of the person and how this might affect their functioning in their daily life. To conduct this test, you need two examiners. Also, you can set the child on the lap of a family member, mainly his mother. One examiner can sit in front the child, and the other examiner can sit behind. The examiner in the front must keep the child's fixation and watch for response when back examiner brings the target around and note the angle of visual field. We also test for color vision because it needs to be assessed as in low vision. There's large number of people have defects in their color vision. And we usually use the Jumbo D15 test, which has bigger size buttons to be easily seen by visually impaired children. Now let's talk about the visual impairment management. So solutions to be recommended to the visually impaired child can be in a form of spectacles, optical aids, non-optical aids, or even advices and recommendations. Some people with visual impairment are more likely to have high and changing refractive errors. However, the optometrists need to be more cautious than usual when prescribing spectacles as part of the visual impaired assessment, because many conditions that leads to visual impairment are progressive and unpredictably progressive. So spectacles are prescribed maybe on use, maybe for use for this person in just a month or two, then they need to change it. So once you have a starting magnification in your head, you then need to consider the nature of the task the person or the child wants to do. In which grade is he now, and where do he sit in the class, and what he's doing usually in his free time. Then you decide the suitable low vision aids, taking into consideration the different features of the vision aids, such as portability, lighting use of hands, lighting and use of hands, availability of electric source, and duration of use. In addition, the weight and size of the device, ability to change batteries, and ability to hold the device during doing the task. Also, an important point is to consider contrast, because some children's reading ability will not be improved as you increase magnification if the main problem is with the contrast. And now let's talk about distance vision, like looking at the board. So the principle for prescribing distance low vision devices is the same as near. So once you have the starting magnification in your head, you should consider the nature of the task the person wants to do and at which distance. If the person is sitting down for the task, then a spectacle mounted device should be considered, like the ones showing in this slide here. For outdoors task, a handheld telescope, as shown in the picture with the girl, is better than the mounted glasses. We have also the electronic aids, which are much more expensive actually, and some of them can be portable and some of them are not. But the very most advantage of them that they can enhance luminance and contrast of the objects being viewed, and over the option of reversing contrast, namely like white print on black or black on white. They can also show yellow on blue and blue on yellow, which has very good contrast for the person if he has very reduced contrast sensitivities. For example, we have the CCTV example of electronic aids, which can enhance contrast and magnify as well to help them to achieve their goals. So optical low vision aids or magnifiers will not be the answer for everyone, for every child, or for every problem the child could have or express. For some goals, advices about lighting or contrast will be very important and sometimes much more important than magnifying. So, such as discomfort glare. If the child has discomfort glare, this can be removed or reduced by reducing light with a tent, by wearing a tent or wearing sport peaks or hat with a burn. A typoscope also is another example, which is a rectangular black card with a central slit showing in this picture here. It can reduce the amount of light from the background and so reduce the scatter and thus increase the retinal image and contrast. And it can also assist reading along lines, finding the next line or guide signing and writing. Also, felt pens can be used to enhance writing with the children who has low vision. So after you finish the assessment and management, writing letters to the schools and teachers are very useful. Make it clear to the teacher. Talk to them about the nature of the child's impairment to make it easier for the teacher to help the child. Make recommendations on the size of a print or printed materials like in exams or the books they want to read. Also recommendations in regards of lighting, the usefulness of spectacles and magnifiers the child may use during education in class and in school. So to sum up, visual impairment is common among children due to several eye or cortex conditions. Vision impairment in children usually means a lifelong disability. The goals and requirements for children with vision impairment will vary throughout these years. So supporting children's and young children's at this vital stage of their life can help set them up to be a confident young adults who are economically active and are key parts of our inclusive society. Here we come to an end of this talk, and I thank you so much for your attention and participation in this webinar.